79% of the Indians have at least one lipid abnormality, as against 53% in US populations. When I used to get an ECG of a patient younger than 35, my boss would say, "Why did you go for ECG?" And exactly about 15 years later, when we became the professor, we said that, "Why did you not take the ECG if the patient is less than 20 years also?" Young patients who have got not only coronary disease and stroke, but pulmonary embolism, the venous circulation is involved, always go for the homocysteine levels. But again, HDL has, now there are reports that too low and too high HDL also is an U-shaped curve.
Hello, thank you for tuning in. If you want to come back to this video later, just tap on the like button. It will save it to your liked videos so it's easier to find. And don't forget to hit on the bell icon to get notified whenever we drop new content. Stay curious, keep learning, and see you on the inside.
Today's topic is really very interesting in the sense that this is something which we day in day out, at least as the family physicians and the internal medicine specialist, we order in lipid profile to almost most of our patients, whether it's a part of health checkup or as a part of workup for diabetes, blood pressure, or any of their illnesses. So I'm sure we are going to have lots of insight from this. And my disclaimer always, I'm neither a pathologist nor an endocrinologist or a diabetologist, not I am a metabolic physician, and I don't claim to be a master or jack of all, even though as a physician. And at least this is not an AI generated presentation, something that we have to now put a disclaimer, because the ready-made presentations are available, but this is certainly not one of them. And I don't have any conflict of interest as far as the financial considerations are there. Again, I'm going to talk about this interpretation of lipid profile under these headings. First and foremost, we need to know, why do we need to know about the lipid profiles? How the lipids are important? Do we really need them? If they are in excess, how harm they do? Then another important concept that has come recently is about the cholesterol years, or called LDL cholesterol years. That's also very important to understand, to know that why we should ask for lipid profile as early as possible to pick up the patients with lipid abnormality, so that we can avail the benefits of the good treatment that is now available easily. What are lipids? What are the lipoproteins that we generally ask for? And what are the parameters and what are the normal values of a lipid profile that we order, and how to interpret them? And should we go for a fasting or a non-fasting lipid profile blood sample? And there are also, once you see the reports, you'll find that the values, especially for LDL cholesterol, would always be mentioned. Two values will be there. One is directly measured, and another is values by calculation method, values derived by calculation methods. And also nowadays we keep on asking for extended lipid profile, at least in select patients. So we need to know what are the parameters that we include in extended lipid profile, and how to interpret them. Before that, we just begin with, why do we need to know lipid levels? We know that the atherosclerotic cardiovascular disease, known as ASCVD, is one of the main cause of death worldwide at all ages, right? Barring probably the head injuries and cancers, it is one of the very important cause of death. And dyslipidemia, or altered lipid levels, are the major contributor to atherosclerotic process. Even though we know that atherosclerotic process has many other factors like age, gender, tobacco, alcohol, lifestyles, lack of exercise, all. But dyslipidemia is one of the major contributor for the atherosclerotic process. And if we talk of Indian statistics, 79% of Indians have at least one lipid abnormality, as against 53% in US populations. To further elaborate for the Indian studies, you can say that more than 50% of the carotid uh, artery disease associated deaths are before the age of 50 years, which is a very huge number. And out of these, 25% of the myocardial infarctions occur before the age of 40 years. So 40 years, before the age of 40 years, 25% myocardial infarctions. I distinctly remember as a um, resident doctors in medicine, when I used to get an ECG of a patient younger than 35, my boss would say, "Why did you go for the ECG?" And exactly about 15 years later, when we became the professor, we said that, "Why did you not take the ECG if the patient is less than 20 years also?" So that is the change in the uh, uh, epidemiology of the diseases, and the disease, at least in India, we can say that the atherosclerotic vascular disease occurs at a younger age, at least a decade earlier. It has a more malignant course than the Western counterpart, and it has a very high fatality rate. So, atherosclerotic vascular disease is a disease to be picked up as early as possible. There is a very famous international study called Interheart study. The results were published in 2004 by the one of the leading author called Professor Salim Yusuf. And what they did, they took about 15,000 patients and 15,000 age match control. Both had acute myocardial infarctions, and though they tried to find out what are the risk factors for the development of acute myocardial infarctions. Those who had acute myocardial infarction, those who did not have acute myocardial infarctions, which served as the control. And this study was spread over 52 countries across all the continents. And what they found out that the median age in of myocardial infarction in Indian patients was 53 years, and that in other countries were 58 years. So 5 years younger were the Indian patients. This was in 2004. And they studied all the risk factors, as I said, and what they found that dyslipidemia has the highest contribution to the what they call it population attributable risk for the CVD death. So 50% of the all these cohorts had dyslipidemia as one of the major contributor for the CVD event. So that was known as a dyslipidemia as a major risk factors before 20 years. This is another very interesting concept that is called cholesterol years or LDL-C years. So we know that atherosclerotic process is one of the important cause, and we need to know by one way or the other what is the atherosclerotic burden in a given patient. So what this cholesterol year concept is that it is just calculated by nothing but the average LDL-C every year multiplied by patient's age. And what it gives is the cumulative LDL exposure to the person's arteries over the lifetime. So, if the person has a cumulative LDL load of 7 grams or 7,000 milligram, he is likely to have when he reaches this target, then he may get an atherosclerotic event. That is what these cholesterol years say. So, based on this, if the average LDL, if we maintain at 100 milligram per year, then the clinical ASCVD event is likely at the age of 70 years. How this concept came, it came from the second line that if the person's LDL is more than 200 milligram year maintained, that he is likely to develop ASCVD at the age of 35 years. And that is exactly what happens in familial uh, homozygous hypercholesteremia patients. We know that it's an autosomal disease, and patients who had homozygous hypercholesteremia usually they succumb at the age of around in the fourth decade if they are not treated aggressively. And that is how this concept has came, and that is one of the rationale for keeping the LDL cholesterol under 100 milligram. And this last one is the just postulations by Professor Eugene Brownlow that if we can maintain this LDL to 70 milligram, maybe probably we will not get ASCVD event before 100 years. But this is definitely important that we have to maintain the LDL cholesterol under 100 milligram if you want to avoid any ASCVD event before the age of 70 years. And that is the reason that we have to pick them as early as possible. We know now that the lipid lowering therapy, if we start early and maintain it for a longer period, which reduces the ASCVD risk much more than putting the patients aggressively when there is any event and trying to reduce the LDL-C at that stage. So it's very important. And now that we have got very effective lipid lower therapy, and it's safe also. We know that most of them are very safe unless they are very high dosage, and that to a very select few patients. And practically, the statins are not expensive. If you talk of the other lipid lowering therapy, recent ones, they may have a cost, but the statins, which are equally effective in measuring the patients, are very, very effective. Do we have the evidence? Yes. We, as this slide depicts, you can see that there is an evidence of clinical benefit of statin therapy for the prevention of coronary disease, whether it's a primary prevention, secondary prevention, or acute coronary syndrome. So, in all the spectrum of coronary disease and all types of statins, whether it is pravastatin, simvastatin, atorvastatin, rosuvastatin, or lovastatin, all have shown benefits for the prevention of primary prevention, secondary prevention, or acute coronary syndrome or coronary disease. Same we can say about the stroke also. And the stroke, they have come out with the figures that if we can reduce the LDL cholesterol by 39 milligram percentage, then the risk of stroke is reduced by 21%. Why we need to emphasize upon the low going for lipid is this reason that if we can pick up the patients early and start the lipid lowering therapy early, definitely we can reduce the ASCVD risk, whether it's a coronary disease, stroke, or peripheral artery disease. So that is why we know. Now we should know what are lipids, right? We talk of lipids loosely, and we when we talk of lipid, we always say it's triglycerides and sterols. But no, practically, lipids are the fatty compounds which includes triglycerides, phospholipids, and sterols. The most important one is cholesterol. The triglycerides again divide into those fats which are solid at room temperature are called flats, and those are liquid triglycerides are called oils. And as you can see from this cartoon, which is taken from the Cleveland Clinic, uh, that triglycerides and phospholipids, the difference is in triglycerides, there are three fatty acid chains with a glycerol backbone, while phospholipids had two fatty acid chain with a glycerol backbone and a phosphate molecule. This phosphate molecule makes it very, very special. Phospholipids is something like an unsung hero that we don't talk about it, but phospholipid is one of the most important lipid which covers all the cells in the body, and this has got a bilayer. These are the two layers. These are this cell membrane, or we call it plasma membrane. We don't use the word wall now. We say membrane because there is an exchange of ions and many other substances across the membrane, which is not possible with the wall. So it's a membrane which used to be called plasma membrane, but for now we call it cell membrane. And there it is covered by the phospholipids. This phospholipids has two heads, as you can see, the head and the tail, two parts. The head and the tail part. The head part is water soluble, while the tail part is fat soluble. And that is how it works. We'll see in the next slide how it works. And cholesterols are, we know that are one of the backbone for the, not only for the cell membranes, but they are also important for the hormone productions, whether it's a progesterone, estrogen, steroids, or vitamin D. And also they are required for the bile acid production, which are required for the digestion of the fatty acids. So definitely we need lipids. By all means, we need lipids as a part of the important source of energy and storage of energy in the form of lipids. It's also required for the cell structures and for the hormone productions. Then what are lipoproteins? Lipoproteins are very, very much important because lipids that we talked in the previous slides, they are not soluble in the blood. They are insoluble. Blood is plasma, is like water. So they are not soluble in blood, but they need to be carried out to the whole body, and they also need to carry to the lymph and the CSF. So that is why the lipoproteins work as a lipid transport system. And there the lipids are incorporated in the lipoproteins. This is a lipoprotein structure where you can see that the phospholipid is the membrane. Again, it is same like any other cell membrane in the body. This has got a bi-layer of phospholipids, and these are the apolipoproteins, which we'll be talking later. And the triglycerides and the cholesterols are embedded or packaged in the lipoprotein molecule, within the lipoprotein molecule. And because of this amphiphilic, or we can say the hydrophilic nature outside and the fat soluble nature inside, this lipid remain, and they are required as and when they are required, they are exported to the other parts of the body. So it is very, very important to understand that the lipoproteins are the one which transport all the lipids, whether it is triglycerides or cholesterol, to the all body parts, right from its absorption at the intestinal levels to the lymph, CSF, everywhere. This is a very, very important slide to understand why cholesterol is very, very important and what are the relative contribution of the proteins or cholesterol or phospholipids or triglycerides in different parts that we study. We usually analyze a lipid profile for very low density lipoprotein, low density lipoprotein, high density lipoproteins, and also chylomicrons, because that is the first part which carries all the digested of fatty acids right from the intestines right into the blood via the lymphatics. So chylomicrons have got 80% triglycerides and very small percentage, hardly 10% cholesterol and 10% phospholipids, hardly any proteins. VLDL has 50% triglycerides, LDL has 50% cholesterol, while the HDL has 50% proteins. So you can understand the cholesterol content is maximum with the LDL. Next comes the HDL and the VLDL, and chylomicron is hardly 10% of the cholesterol. So this is very, very important to understand why we need to control the LDL, because that is the major contributor for overall cholesterol. And another important part is the density. If you go from chylomicron to HDL, the density increases. It's from 0.93 to 1.063. And if you go, the size part is reducing from here to here. So HDL is hardly 5 nanometer. LDL is 25 nanometer, VLDL is 30 nanometers, and chylomicron is 75 nanometers. So this is very important to understand why we need to control this. The reason is chylomicrons and large VLDL particles larger than 75 nanometers, they cannot enter the intima where the process of atherosclerosis starts. This is a very important slide to make you understand this. HDL, LDL, lipoprotein A, LDL, IDL, small VLDL, all can pass the intima and start the process of atherosclerosis. This is the arterial wall, this is the plasma. But chylomicron and very large VLDL cannot pass. So that is the very reason that we have to concentrate on LDL and the lipoprotein A. Now coming to the actual topic of lipid profile, that why we need to go for lipid profile and who are the persons whom we should order lipid profile. All persons ideally above the age of 18 years should at least get one lipid profile as per the Cardiologists Society of India guidelines. Then those who had a family history of dyslipidemia or premature ASCVD, they also need to undergo, because familial hypercholesteremia is an autosomal dominant disease. It may manifest little later, but it's an autosomal disease. All persons whom we examine routinely, and if we find some evidence of dyslipidemia in the form of whether it's a xanthelasma, which are the yellow deposits near the palpebral fissure, or arcus senilicus, or xanthoma over the tendon xanthomas over the middle carpal extensor tendons or the Achilles. If we find any of these in any patient, younger patients, at least get their lipid profile once. If the person has recent history of any cardiovascular events or diabetes, hypertension, chronic kidney disease, metabolic syndrome, obviously we have to go for lipid profile. Very important point to remember that if the patient has some illnesses or injury, then we may not get the correct picture of the lipid status. It is better that we repeat the lipid profile once the acute event is over. As far as the lipid profile indications are concerned from the US counterpart, the CDC recommends, at least in the children, if there is a family history or suspicion of familial hypercholesteremia, that all children should get at least one cholesterol check between the age of 9 and 11 years in childhood, and for adolescents 17 to 21 years. So at least our recommendations of 18 years definitely is worth keeping in mind, and we should get lipid profile at least once for after the age of 18 years. Now, what are the important parameters and what are normal values that we look for? We get total cholesterol, triglycerides, HDL cholesterol, LDL cholesterol, VLDL cholesterol, non-HDL cholesterol, which is the total cholesterol minus the HDL cholesterol. Then ratio of total to HDL, LDL to HDL, and triglycerides to HDL ratios. Of course, these ratios are not now very, very important as far as our targets are concerned, is mainly the total cholesterol, LDL cholesterol, and non-HDL cholesterols. The total cholesterol should be under 100 milligram. That is the ideal. Borderline is between 200 to 39. Of course, this has to be interpreted with whether the patient has comorbid conditions like diabetes or chronic kidney disease or had any severe event in the past. Then obviously it has to be a less than 200 milligram. LDL cholesterol, one of the main target for the reducing the lipids or the cholesterol or ASCVD, as the optimal should be less than 100 milligram. Again, this will also go further down depending on whether the patient has diabetes. Now it has come down that every patient with diabetes LDL should be preferably 70 milligram, and those who had the events, recurrent events, even it can go up to 55 milligram, and the highest risk, those who had recurrent events after the procedures, even we can try to get the 30 milligram, which is not that easy to get it, but if it is possible, we should try to lower the LDL as low as possible in select patients. HDL cholesterol is now not as much importance as it used to be receiving earlier. The reason is we don't have any therapeutic options for the raising the HDL cholesterols, and whatever options is to be there advocated again has not proven effective enough. But the HDL cholesterol should be less than 40 milligram is called low, and those more than 60 is called high. And female it is usually around more than 50, and male it should be at least 40, 45. Triglycerides again are re-emerging as an important target for therapeutic target after controlling the LDL. We'll see why. The normal triglycerides should be less than 150 milligram. Height are obviously more than 200 is high. Triglycerides which are beyond 400 are definitely the target for therapy for a different indications to prevent the gallstones, pancreatitis, and all those things. But even as a part of lipid abnormality, triglycerides are again re-emerging as an important target. We'll see that. The unfortunate part is that the lipid profile, if we do at 2, 3 different laboratories, definitely the values may be different. And one of the speakers in one of the forums said that the best way to reduce lipid profile is to change the laboratory. Or that is what our patients do. Smart patients get it done in 3 laboratories, and whichever is the lowest, they'll come with that report to us. So you have to be very important to see the credibility with what methods they have done it and whether they follow the standard prescribed methods for carrying out the lipid profile. Now, another important concept is whether we should be going for directly measured values or calculated values. The total cholesterol, triglycerides, and HDL are always measured directly by the direct methods, that is called calorimetric methods, that is, or enzymatic methods. They are always done directly. So there is no dispute about these 3 values. When we talk of total cholesterol, it includes HDL cholesterol, LDL cholesterol, intermediate density lipoprotein cholesterol, VLDL cholesterol, lipoprotein A, chylomicron, and remnants. So all this comes to total cholesterol. If you minus the deduct HDL cholesterol, probably what we get is a non-HDL cholesterol, which is now considered as a co-primary target. It's not only the LDL, but we should be targeting non-HDL, as if you can see in the previous slides, that less than 130 non-HDL cholesterol is an important target. So we should be going for this. The LDL values are derived by most of the laboratories through their formula only. They don't do LDL cholesterol. It's a separate method. They have to do it. And most of the laboratories, they do it by what is called a fried wheat formula, where the LDL cholesterol is total cholesterol minus HDL cholesterol values minus the VLDL cholesterol. Only 20% of the triglycerides is a VLDL. So triglycerides into 0.2 is the VLDL. So total cholesterol minus HDL minus VLDL, you can say, is the LDL cholesterol. Only thing is that this formula is validated only if the triglycerides are under 400 milligram. And these values are again validated only for the fasting samples. So nowadays that we advocate more of non-fasting samples, right? Why we talk in the next few slides. But that is where this fried wheel formula would not uh, be applicable. Best thing is to go for the total cholesterol minus the HDL cholesterol because both are directly measured and we get the non-HDL cholesterol. The fasting versus the non-fasting samples. Up till now, most of the laboratories, most of the doctors, most of the associations and organizations were advocating for fasting lipid samples. But of late, people have been doing it with non-fasting samples. The advantages of fasting sample, the reasons for fasting samples were that they were the ones which believed that probably we get the fasting samples, we get the best lipid profile. But in fact, the fasting samples will have the lipid profiles only from the hepatic origin lipoproteins. And it's more of a belief that the lipid profile has to be done in fasting samples. And most of the earlier studies were done only with the fasting samples. But in fact, it is very inconvenient to the patient, right? If you ask the patient to have an 8 hours of fasting, right, and then go to the laboratory for just giving a blood sample and they return, right, it's inconvenient. While as against that, the non-fasting patients, whenever he comes to the clinic or laboratory, he can just give the blood. And most importantly, the fasting sample contains only the hepatic origin lipoproteins and patients who are having an oral hypoglycemic agents, right? If they have to keep a fast, right, and if they buy somehow the fasting is delayed, they have a danger of hypoglycemia. As against that, the non-fasting samples you can give anytime. It's very convenient to the patients, and one simple visit on his way home, office, whatever, he can give the samples. And now, most of the studies include both states, fasting as well as the non-fasting states. And there are enough evidence to say that non-fasting lipid profile levels are in fact better and they represent a better atherogenic lipoprotein levels because most of our own system is more prandial, postprandial rather than the fasting state. And all the non-fasting samples includes not only the lipoproteins of the liver origin, but also from the remnants lipoproteins of the intestinal origin, which also contribute to the rising cholesterols and triglycerides levels and eventually to the atherosclerotic process. So now most of the laboratories have shifted, or most of the doctors have shifted to the non-fasting lipid levels. The what is the difference between fasting and non-fasting? The major difference is only in triglycerides. Only in triglycerides. The triglycerides, the maximum mean change of non-fasting versus fasting is 26 milligram higher in the non-fasting state or after meals, anytime after some food or not fasting, typical 8 hours fasting, there is a rise of 26. But otherwise, the total cholesterol, LDL cholesterol and non-HDL cholesterol are minus 8 milligram percentage. And this has been derived from a study of more than 90,000 subjects in a Copenhagen general population study and after normal food. So these values have been often quoted as the reasons why we should be going for the non-fasting state. And if you can see, the only difference is if you go for fast triglycerides, it should be less than 150 for the fasting state and 175 if you add 25 milligram. That is the only where probably the targets may be different for interpretations. Otherwise, nowadays it's better that we go for non-fasting samples only. The good part is that HDL, ApoA1 and ApoB are not different whether it's a fasting state or a non-fasting blood sample. Now, triglycerides. As I have been telling that triglycerides are getting a very important importance for the reasons that hypertriglyceridemia is not an innocent bystander. The composition of LDL and HDL particles change with the levels of triglycerides. If one person has a triglyceride of less than 100, the other person has a triglyceride of more than 100. Person with a triglyceride of less than 100 will have more of phenotype A type of large buoyant LDL. The LDL also of different sizes. The large buoyant LDL called fluffy uh, LDL, which does not get attached to the intima as frequently as the small dense LDL, which is called phenotype B, which is increased in the proportion if the triglycerides go beyond 100 milligram. So that is why the small dense LDL particles are more atherogenic, and their percentage will increase once the person's triglycerides go beyond 100 milligram. And that is why, even though the most of the associations organizations would say that keep the triglycerides under 200, it is better that we try to keep the triglycerides as close to 150 or less, so that the amount of small dense LDL becomes less and less. Next is what is an extended lipid profile. Extended lipid profile is lipoprotein A, right? It is written LP little a, apolipoprotein A, apolipoprotein B, and homocysteine. These are the tests we do not routinely ask for, but probably we should be going for extended lipid profile in all persons who have a family history of hypercholesterolemia or premature atherosclerotic cardiovascular disease, persons who had a very high risk of ASCVD like obesity, persons who are consuming tobacco, diabetes, or had hypertension or CKD. And despite of optimum lowering of LDL, if the person develop ASCVD event, then we should be going for all this extended lipid profile. Extended lipid profile adds to the cost but gives enough informations. And we have seen so many times, at least in the young patients, that we should be going for this. And these are the values usually you don't need to do repeatedly, because at least once get LPA. So what is LPA? LPA, most of the people believe that LPA is a part of LDL, which is not true. LPA is like LDA as far as the structure is concerned, but it is not LDA. LPA is separately measured and it is distinct because it has gotten extra apolipoprotein ApoA. Most of the LDL cholesterol have one apolipoprotein molecule for one molecule of the LDL cholesterol, uh, one only. But here for LPA, there is one for LDL like structure plus one for ApoA for extra lipoprotein. And that is a specific, uh, this is called a kringle or kringles, and is a trisulfide bonds. And this extra attachment of the apo makes it more prothrombotic because it has a structural homology of plasminogen, which we know is a procoagulant. Plasminogen, urokinase, they are all procoagulant. That is why persons with LPA will have more chances of developing the thrombosis. They predispose to aortic wall calcifications, at least in patients with familial hypercholesteremia. And high levels of more than 50 milligram LPA is definitely an inheritable risk factors for ASCVD. More than 50 milligram of LPA is a risk factors for ASCVD, irrespective of the level of LDL or total cholesterol, right? But very importantly, we have seen many persons who are being all asked for LPA again and again. That is not true. That's not required because LPA levels do not change over a period of time less than 10%. So it should not be done repeatedly. It should be done only once or at the most twice, but it's not been repeatedly. If we do it, if we try to intend lowering the LPL, that's a different thing. So LPA can be targeted as a therapeutic option. Then we can definitely ask for the repeat LPA after smashing the treatment. And this has become important after the availability of PCSK inhibitors, which have reduced the LP also by 25%. So that is why the interest in LP has further increase because of the availability of drugs which can lower the LPA. Otherwise, statins do not have much effect on the LPA. Apolipoproteins. Apolipoproteins, as we have shown earlier, also they are the part of the structure of the lipoprotein. They are also the assembly of amino acids, but they have got different functions and they are given by different names because of the structural difference. The apo A, B, C, E. These are the apolipoproteins available. These apolipoproteins, they definitely help as part of the lipoproteins, the transport of the lipids, but they also work as a cofactors for the enzymes for the lipid metabolisms. And these lipoproteins also work as ligands for the identification or recognition over the cell surfaces. And that is how they are taken up by the liver and cleared. So it helps in the metabolisms, it helps in the detections, it helps as a cofactors and transport. So apolipoproteins are very important, and at least it should be ordered at least once, I would suggest. And the most important apolipoprotein is ApoB. ApoB is an atherogenic lipoprotein. As we have seen, we have got LDL, HDL, VLDL, IDL, and chylomicrons. Apolipoproteins is one of the key component of LDL, IDL, VLDL, and even lipoprotein A, as we just saw, right? While ApoA is only for HDL. So apolipoprotein B is synthesized in the liver and also in the liver, which is an ApoB48, which is mainly present in chylomicrons and remnants, and this is the one which carries the digested uh, fatty acids to the liver. In liver, there is ApoB, which becomes the main component of LDL, IDL, VLDL, and lipoprotein A. We should aim to bring the apolipoprotein levels, B levels, to less than 100 milligram. If it is more than 140, it's a very high levels. So it's very important whenever we order ApoB and ApoA, we should know what are the normal values. It should be less than 100 milligram, preferably, right? And it's very important because ApoB is the one which initiate the process of atherosclerosis in the subendothelium. So ApoB levels, unfortunately, the uh, it's not easy to understand or define how much ApoB is reduced by the statin therapy. Statins reduce LDL more than the ApoB. So that is how really the lipid lowering therapy is one which we keep on doing it as LDL. But ideally, after LDL, we should go for BA to see the efficacy of the treatment because ApoB is not reduced as much as the LDL. The ApoA is mainly synthesized in liver. It is the major apolipoprotein in HDL cholesterol. And we know that HDL cholesterol one which helps as a reverse transport of the cholesterol. From the periphery, from the tissues, the HDL works as a scavenger. It brings the LDL to the liver while the LDL is metabolized. So HDL is a reverse transport. LDL is a forward transport. It is a reverse transport. ApoO levels should be between 110 180 for males and 110 to 205 for females. It's very important to go for the ratio of ApoB to ApoA. ApoB is more atherogenic, ApoA is more protective. So if the person's ApoA is high and B is low, the ratio is, if less than zero point 0.6, it is what is desirable. If it is more than zero point 0.8, it contains high risk. So always go for ApoB to ApoA ratio. And ApoB to ApoA ratio has one advantage, that if you go by the ratio, that ratio confers an increased risk independent of the LDL and HDL levels. Person's LDL, HDL levels may be anything, but if the ApoB ApoA ratio is more than 0.8, it carries an further risk of ASCVD. So always go for ApoB and ApoA ratio. And the last one is homocysteine. Homocysteine, we keep on reading about the homocysteine is one of the important risk factors. And of late, or patients who have absolutely normal lipid profile, and if they have an ACD event, or then we should go for homocysteine levels. Homocysteine is not available in plant foods or not available in our regular food. It's available mainly in the animal foods, except in dairy products and nuts, few nuts. Homocysteine is not available. It's mainly available or synthesized from the methionine, which is abundant in all these products. Homocysteine is a key determinant of methylation cycle. Methylation cycle is the one which decides the DNA synthesis and many other enzymatic reactions in the body. The homocysteine is circulating levels are always low, less than 15 uh, millimicron per liter, and the reason is that it is metabolized rapidly. Homocysteine is one which is either converted to methionine or converted to homocysteine. So if it is metabolized by remethylation pathway for requiring, if the body needs methionine, it regenerates from the homocysteine by vitamin B12 and folate, that is called the cobalamin pathway. But if the methionine is not required as in excess, it's converted into cysteine, which is by the pyridoxine pathway. That is why vitamin B12, folic acid, and B6 are required, or we routinely prescribe patients who have got hyperhomocystinemia, so that the homocysteine doesn't get accumulated and produce its harmful effects in the form of endothelial cell damage, hemostasis, or neurodegenerative disease like Alzheimer's disease, depressions. This is very, very important, that homocysteine affects the arterial and venous thrombosis. So patients, young patients who have got not only coronary disease and stroke, but pulmonary embolism, the venous circulation is involved. always go for the homocysteine level. So homocysteine levels should be less than 15 micromole per liter. Anything more than 15 is high, but people consider 15 to 30 is moderate and more than 30 is high. But homocysteine levels definitely is one of the important extent lipid profile required where there is no obvious abnormal lipid and routine lipid levels. So we can conclude or summarize that we know that dyslipidemia is a major contributor to ASCVD, right? Most of the Indian patients have more than 80% have one lipid abnormality. If we can detect and manage dyslipidemia at a younger age and sustain it for a longer period, definitely we can reduce the cholesterol burden over the years. Emerging evidence is now for the non-fasting lipid profiles, and the non-HDL is a primary target now for LDL over and above the LDL cholesterols. But whenever the patient has a higher risk or patient develops an event, or LDL levels are maintained, but still patient has signs of ASCVD, then it's better to go for extended lipid profile. Thank you. If there are any questions, definitely, or if there are any comments, we can discuss.
Uh, that wonderful discussion. We do have some questions coming in from our doctors. We will be getting into that. Taking one of the earlier questions that we had from Dr. Arun, 30 years old with LDL 192, HDL 38, TG 104, asymptomatic, not diabetic. Family history of dyslipidemia. What is the recommended statin and dose?
Yeah, definitely. This is a case of familiar dyslipidemia. And usually, familiar dyslipidemia, if it is hypercholesteremia, there are two varieties, homozygous and heterozygous. Homozygous means both the parents are it's an autosomal dominant, and there would be some signs of dyslipidemia in the form of xanthoma, xanthelisma, or arcus analyticus, and they need to be treated very aggressively because most of the patients are dead in their fourth decade. But heterozygous hypercholesteremia like this, wherein the triglycerides level would be normal and that LDL level would be high. But usually LDL levels are expected to be more than 200. This is almost 192. And if there are any evidence, other evidence, or irrespective of that, I would definitely start the high dose of statins, definitely. And I will convince them to get the screening also for, as I said, the extended lipid profile also and the LPA also, and would start with anything from 20 milligram of rosuvastatin or 40 milligram of atorvastatin.
Next is from Dr. J. Do we need to initiate statins for 39-year-old men with increased LDL 140 and total cholesterol 220? Doesn't have any cardiac symptoms, BMI is normal, no other risk factors, BP is normal, but has family history of hyperlipidemia.
Surely, so that is what exactly this very topic of discussion is, that the concept, as I said, about the cholesterol years, that if we can prevent the cholesterol loads, right, prolonged sustained cholesterol levels or cumulative cholesterol exposure, definitely we get a better chance of reducing the ASCVD risk. And for any levels, whether it's a previous case or this case, in my practice, I would always first inquire about the lifestyles, right? Whether we can reduce it, because we know that the lipid levels in the blood are contributed by two factors. One is the hepatic productions of the cholesterol. Cholesterol is synthesized by the liver, but second important contributions come from the diet. In most of the patients, by and large, the dietary contribution is around 20%, 20 to 25%. So if we can cut down that to as low as possible by the lifestyle changes in the form of reducing the fried food, fat food, and increased exercise and maintaining the weight, if we can bring about this change. So it's not that in the previous case or this case, I would start on the very first visit or the first lipid profile level. But if after 3 months also the lipid levels have not changed significantly, if they remain above, I would say 120, I would definitely start the treatment, definitely, even if there are no risk factors.
Next question from Dr. Kulkarni. Do you advise aggressive treatment in case of familial hypertriglyceridemia, even though parents had high triglyceridemia and lived more than 90 years?
Surely, definitely. And for very high triglycerides, as I said, we are worried more about the gallstones and the pancreatitis events. That is one. And as we just discussed, it higher the triglycerides, higher the chances of LDL, because they change the composition of LDL if the triglycerides levels are high. So even with that in mind, triglycerides need to be treated. If the cholesterol levels are normal, absolutely normal, only triglycerides are high, then if we have the facilities are available, we can look for whether are suffering from the different types of hypercholesteremia. That is, we know that there are different types of hypercholesteremia. That is, phenotype 1, 2, 2A, 2B, 3, 4, and so only if triglycerides are high, and if you can pick up the genetic abnormality, which I am not sure whether it's done routinely at most of the places. Barring that, if the cholesterol triglycerides level are high, we should go for, because triglycerides high could be as a part of the insulin resistance, also in part of the right the harbinger for diabetes, or most of the patients might even blood sugar higher on that higher side. So we would go for it, irrespective of whether the patients have family history of longevity.
Dr. Maheshwari asks, statins given for many years are justified even though lipids are normal for months.
See, what that depends on what you consider is normal, right? If it is maintained, say, suppose if I started a statin as a dose of 20 milligram of rosuvastatin, right? And after 3 months, from 150 it has come to 100. It's still not at the target level. With the target level, I would not reduce the dose. But if it has come suddenly to 40, surely I'll reduce from 20 to 10 milligram. But patients who had a very high statin levels, LDL levels earlier, most of them would be requiring some dose of statins, depending on the levels that we keep on doing subsequently.
Next is from Dr. Joy. What is the treatment of high homocysteine?
Same as I said, that a hyperhomocystinemia, we have to find whether it's a primary or secondary. What we mean by secondary is there can be many causes like hypothyroidism, diabetes, chronic kidney disease. Some of the drugs like methotrexate will give you affects the folic acid metabolism. So methotrexates and those drugs. So we have to look for the cause of hyperhomocystinemia. If there is no other cause other than many of the vegetarian patients, they have got hyperhomocystinemia because they are deficient in vitamin B12. So if we can find the cause, secondary cause like hypothyroidism, diabetes, we treat them. Otherwise, all hyperhomocystinemia patients should be receiving vitamin B12, folic acid, and pyridoxine.
Next from Dr. Shah, ApoB lowering agents.
As I said, there are no ApoB lowering agents. In least the statins does lower the ApoB also as much as LDL, not as much as LDL, but if the LDL is reduced by 50%, ApoB will be reduced by 15%. So I am not aware of only ApoB lowering agents as of now available, but definitely there are going to be the drugs which would reduce the ApoB levels also. I'm not very sure about these newer PCSK inhibitors and drugs, they reduce the ApoB levels, but new drugs have come that is called lomitepide, or that is a drug which reduce the cholesterol synthesis, lomitepid. So definitely that will also reduce the ApoB levels, but that's not available here. But that new drug has come, and maybe that will come after some time here. But there is a drug which is available, and it reduces the cholesterol synthesis in the intestine itself, from where the ApoB also comes.
Dr. Gupta asks, what is the ideal time for taking non-fasting lipid profile samples?
See, as it is, as we say, non-fasting level means any given time, but preferably after 2 to 3 hours, because the maximum triglycerides that change that we see is within the 2 to 3 hours time. But otherwise, it will not make much difference except we give the allowance for the triglycerides to be on the higher side by about 25 milligram percentage.
Dr. Sharad asks, my HDL remains near normal even though I'm an athlete. Does it require to chase no DM or hypertension?
No, there is two things now. HDL, as I said earlier, also that HDL is reducing its importance as far as the correction of HDL is concerned. Low HDL is definitely a negative risk factors, but that doesn't mean that we have to attend it, because all the drugs which try to increase the HDL, we did not see the market because they were very toxic. The cholesterol CETP inhibitors drugs, we did not come to the market because of the side effects. And exercise is supposed to increase HDL, but again, even small amount of alcohol was considered to be good for the increase in the HDL, but none of them stood the test and these validations. The important thing is HDL itself is also now just like LDL, small and dense LDL and large going to LDL. HDL also is HDL-3 and HDL-2 that most of the laboratories do not do it. In an experimental or very few laboratories will be doing the sub fractions of the HDL, whether it's HDL-3 or HDL-2. So maybe the person's HDL will be normal, but the main HDL protection comes from HDL-3, HDL-3C. So, which if it is enough, right, then probably we don't have to worry. But again, HDL has now there are reports that too low and too high HDL also is an U-shaped curve. So, best thing is we don't chase HDL. If there is no diabetes, no hypertension, the lipids, LDL, and triglycerides are normal, then we don't have to worry about the HDL.
So Dr. Bhargavi asks, sir, aspirin should be included along with statins for every hyperlipidemia, or how to decide the combination or single? Please explain.
A very good question. See, aspirin is given mainly as an antiplatelet agent, and we know that once there is a process of atherosclerosis, atherosclerosis process starts at the intima. And once the intima is roughened, right, because of the LDL, you are going to attract the circulating platelets, which are otherwise in an inactive form, right? They get activated and it start the process. So aspirin, yes, if you but that aspirin is double-edged sword in the sense that not that every aspirin is good. I would say aspirin has more side effects than the statins in the sense that aspirin does produce gastritis and the occult blood loss in so many patients. So there are clear-cut indications if the patient is more than 60 years on any comorbid conditions, definitely it's a case for aspirin. And patients who had already an event, which is a secondary prevention, aspirin is definitely cornerstone with statin therapy. But as a primary prevention, aspirin is not indicated in each and every patient who has got hyperlipidemia.
Dr. Sushant Kumar says, sir, regarding the treatment of dyslipidemia, which group of statins with the least side effects should be prescribed until what duration?
This is not for the statin treatments, where we wanted to discuss mainly lipid file, but fine, I can take these questions. See, basically, statins are the earlier generation statins were lovastatin, simvastatin, pravastatin, while the newer generations are atorvastatin, rosuvastatin, and pravastatins. The statins are the lovastatin, pravastatin, and simvastatin. That earlier statins were all synthetic statins. I mean, natural statins. They were derived from the fungi. While the newer statins, the atorvastatin plus these rosua and pitavastatin, they are all synthetic statins. Then again, statins are divided into hydrophilic and lipophilic. So hydrophilics are mainly to rosuvastatin and pitavastatin, while lipophilic are atorvastatin is one of the main that we now use it. So the question is, the side effects depend, most of the time the side effects are not related to a group of statins, but theoretically, because atorvastatin is lipophilic, it is likely to have more muscle-related side effects, while rosuvastatin and pitavastatin being cleared by the hepatic. So if there are altered liver or liver toxicity is more likely with the rosuvastatin or pitavastatin. So question comes, if you start any statin at an equipotent dose, that means the equipotent dose is 10 milligram of rosuvastatin is equal to 20 milligram atorvastatin, and for 2 milligram of pitavastatin. So this is the equivalent dose. We don't use now simvastatin or we don't use pravastatin or lovastatin. So we are not talking that. The main three statins that we use are mainly rosuvastatin, atorvastatin, and pitavastatin. So 20 milligram of atorvastatin, 2 milligram of pitavastatin, and 10 milligram of rosuvastatin are equipotent. So if you start at equipotent dose, they should have the same lipid lowering effect. If there are side effects, as I said, if there are muscle side effects, I would switch over from atorvastatin to rosuvastatin. If the liver enzymes are increased, then I will switch from rosuvastatin to atorvastatins. Duration, as I said, as long as we need to control the lipids, that means practically infinite.
Dr. Mishra asks, diet and management of dyslipidemia.
Yeah, we also discussed this part that, see, basically the dietary contribution of the in the lipids is around 20-25%. So definitely those but this is normal. But patients who have been eating left and right all the fast foods and all the fried foods and sweets and all, definitely we need to cut down all this. We should encourage more of the fruits, vegetables, right? More that is with the high roughage and less of the triglycerides and the that comes from the food. And if amongst the food, we can say that out of the fat, right, contribution that is usually 7 to 10% of the total diet, we should more go for the nuts, right, or especially the almonds and walnut, and we may prescribe more of avocado and all those chia seeds and all, because that will help definitely in increasing the mufa and pufa rather than the saturated fats. But overall dietary influence on the lipid would be not much unless the patient's diet style is very haphazard or on the wrong side.
Next is from Dr. Mahajan. Patient with TG 260, LDL 104, VLDL 51, and total cholesterol 193. No history of DM and hypertension. What treatment should we start?
Again, as I said, see, the point is that he's definitely the triglycerides are on the higher side. I would definitely like to go for the see whether he has signs of insulin resistance or diabetes and HbA1c fasting. That I would check first. What is his weight that we need to check? And this is not the level that definitely will be starting the treatment, but will definitely advise about uh, them about the lifestyle changes and repeat the lipid profile. This is not the time when we should be starting any lipid lowering therapy, surely, this patient.
Dr. Rahim, age 49, male, total lipids 853, cholesterol 350, TG 179, LDL 251, HDL 45, no diabetes, no hypertension, no family history. Management, please.
See, any cholesterol more than 350 or LDL more than 200 definitely as a part of the familial hyperlipidemia, or they need to be treated, right? And again, the answer remains same, that we need to check for whether there are evidence of the xanthoma, xantherisma, or arcus anglicus. And we also need to go for whether there is any secondary cause of hypercholesteremia like nephrotic syndrome or chronic liver disease or hypothyroidism. These are the secondary causes of hypercholesteremia. If they are not present, then definitely after the dietary advice, after 3 months, I would be putting them on high dose statins.
Dr. Mani says many times anti-liver patient shows normal lipid profile. Please comment.
Well, I'm not very sure about whether there can be any other reasons than the hypercholesteremia, but maybe we need to check the lipid profiles again, right? Because there's one of the clear-cut indications, means a sign of the familial hypercholesteremia.
Dr. Vinod says there's some genetical hyperlipidemia. Statin is not indicated. So, what is the management without statin?
I do not agree with the genetical hyperlipidemia doesn't require. No, statins are definitely required. In fact, a very high dose of statins are required, but only if you mean that LPA part. If there is only increase in the LPA, statins do not work much. But that's not that we all hyperlipidemia other than the LPA increase, statins would not be useful. Beyond statins, we have got ezetimibe as one of the drugs, right? That now being used very frequently. We also have a drug called bempedoic acid that we use it. We also use the newer drugs are now available, like the PCSK inhibitors, and even inclisiran is also available. So we have got many other drugs which can be tried, definitely. But statins do work. Only thing is, it may not work as efficiently, or it may not lower down, and we may have to add other drugs like ezetimibe. Ezetimibe now almost a co-prescription for the reasons that when we start with the LDL, lowering therapies, right, it reduces the hepatic production is reduced, but that leads to compensatory increase in the intestinal absorption. So if we add ezetimibe, it would work in more synergy than using only one of the statins. That is why it is said that more than, if you use atorvastatin 20 milligram, it is better to use 10 milligram atorvastatin and 10 milligram ezetimibe. So 10 plus 10 is more than 40. That is what they claim. And in fact, it is. So ezetimibe definitely is something that we can definitely add to it.
Next is from Dr. Purohit. What is your clinical experiences with micomycin?
No, not okay. No idea. It's also is I think one of the drugs like the lomitepide, right? But I have no idea.
Dr. Shrikant asks, how often should we repeat the lipid profile for patients under treatment?
That's a very, very important questions. And normally, once we do it when we are at the titration stage, once we have diagnosed and lipid abnormality, we start with a particular dose, and we try to achieve the target levels. If the target levels are achieved consecutively for 2 quarters, maybe we can repeat it only once in 6 months, provided we are sure about the patient's compliance for the medicines as well as the lifestyle. So once in 6 months would be sufficient if the patient is reliable. Otherwise, every quarter.
Um, Next is from Dr. Umar. What is the drug of choice in CRD who has triglyceridemia?
CRD means chronic kidney disease. Is that what they mean? I'm not sure what he means.
Dr. Nazir, if you could elaborate, and till then we can
Is it
move on if
CKD
you have.
what you mean? And
Dr. Nazir means CKD, sir.
yeah, so basically, triglycerides, as I said, that triglycerides, we have to find out what is whether it's a secondary to diabetes or is a part of the CKD itself, right? Triglycerides per se, we start with fibrates usually. We can use it up to a certain levels of the eGFR, but triglycerides in presence of CKD will be interested only if the triglycerides are extremely high for preventing the gallstones and the pancreatitis. That's our main goal, not the goal of reducing the triglycerides in face of CKD, right, with the drugs which could be harmful. And the statins do reduce the triglyceride levels also, and statins are safe in CKD. So definitely we can be starting with the CKD. We can also start with the drugs like fish oils. They are also safe. And then we think of the drugs like fibrates.
So next is from Dr. Gupta. Should a break be given during continuous therapy and for how much time?
As such, there is no such break therapy I'm aware of, right? The reason is simple that once you stop the medicine, these medicines work straight away as the production level HMG CoA inhibitors, that is the cholesterol cycle, that is where it works. So if you stop it, it's going to go back to the original production of the cholesterol. So theoretically, there is no reason why we should stop unless the patient is co-prescribed with other medicines which are more hepatotoxic. Patients has developed tuberculosis and he has to be given the anti-TB medicines. And if they are along with all any such drugs, if there is statins are not tolerated, we may stop it. Then we resume once the liver functions return. But otherwise, we don't have to stop as a part of lipid lowering therapy. There is no holiday like that. We keep it for drugs like the biphosphonates for osteoporosis, where the mechanisms are different.
So, doctors, since most of your questions are similar, hopefully you got it answered. In the interest of time, we are going to take one last question from Dr. Upadhyay. My patient has LDL level 3.6, total HDL ratio is 4.3. Which ratio should I be looking at, as there is a difference of opinion on whether to prefer medicine? Do not have any other health issues.
Uh, I do not understand what you mean by LDL level is 3.6. Is that what they talk of the moles? Right, then you have to multiply it by 40, because then it comes to around 126 or something. And even then total to HDL ratio 4.3, or it's we need to know the total cholesterol levels and the non-HDL levels. But if the LDL level, if I go by 3.6 as the mole and multiply it by 40, right, that's going to for 120 plus another 10. So definitely it calls for the treatment. But best thing is to, if ever in doubt, we repeat the lipid profile levels and overall evaluation. It's not that only we should look for one single lipid profile level to start the medicine, which we have to take it for a very long period, right? But nowadays, ratios are not as important as the values. That much I can say. If I have to rely on two, I would rely more on the levels rather than the ratios.
With that, thank you so much, sir, for taking in so
Thank you.
many questions from our doctors.
I
Thank you
also
once
enjoyed
again.
interacting. Yeah,
Right.
good number
Thank you once again for this
and
wonderful
thank you.
session.
Yeah,
Thank you so
thank
much,
you.
sir. Thank you, doctors, for asking your questions with so much enthusiasm. Hope you had a great time. Thank you once again. Thank you, sir.